Hugh Montgomery, just tell us first just how stretched you are. Paint a picture of what it's like there in the ICU.
So this is very, very busy. So the number of patients we've got in hospital now exceeds that we had in the first wave. And whilst we understand the disease better, which means we're not being blindsided the whole time, we don't have new therapies that are very effective. Steroids are marginally beneficial for a few patients, but there are no big game changers here. So the work is every bit as busy as it was before. The wards in most hospitals are now completely flooded. The emergency departments are flooded. There are problems with oxygen supply. We're back to running out of machines in a lot of hospitals. Nursing staff are overstretched. We're really back to where we were before.
And what happens if you get even more patients, as it seems inevitable that you will, looking at the figures?
It's going to be very difficult. I mean, a lot of my colleagues have had this dreadful problem for some months already, running at 200 or 250% capacity, so twice as many patients for the same numbers of doctors and nurses. And they've been doing this for some months. Of course, London is just catching up to where that was, and we've been hit really badly in the last couple of weeks. The issue is, as was before, in many hospitals, we can start putting 2 beds into each space or more. We have enough breathing machines around, but the problem, as always, is staff. It takes a decade or more to train an intensive care consultant. It takes a long, long time to train an intensive care nurse, and you can't just grow them on trees. So this is the problem. And out on the wards, the same. Bearing in mind that as we all get lathered in COVID, staff contract it and go off sick. And so the numbers of staff start falling as the number of patients starts going up. And it's making life very, very difficult already.
Is there a way to rapidly get more staff on stream, or are you going to have to very soon start choosing who gets life-saving treatment and who doesn't? Is that already happening in some places?
No, I'm not aware that it is happening. And certainly in my own practice, I've never, ever had to make that decision, and I never would. My view is if you need intensive care, you'll get it. The people who are declined intensive care are ones who we feel where that care would be futile. So I'm not aware of any such rationing having taken place before, and I don't think it is likely to happen, because staff will stretch themselves increasingly, and we haven't yet found where the limit of that elasticity is. So nursing staff and doctors will take more and more work on. It just makes it harder and harder to deliver the same quality of care that we would normally.
So do you try and get more medics back from retirement? What can you do? Or is it just a case, as you say, of stretching that elasticity with potentially massive impacts to your own mental health and well-being?
Yes, and the stretch is particularly for the nursing staff. They are the ones who are getting absolutely pushed. I mean, I don't think people understand in emergency medicine nursing and intensive care nursing what a complicated job that is. It's really, really difficult. And you can't just add a second patient on. It's not simple nursing care. It's very complicated indeed. So it's those people I'm worried about getting the major hammering. The medical staff can cope to a degree. The other problem, of course, is quite rightly, we have to try to maintain some sort of NHS service. So if people are sick with other conditions, we do have to try to look after them. And we can't do what we did in the first 6 weeks of lockdown and just say, this is fully COVID, and unless you're really gravely ill with an emergency, we can't look after you. So we are, in every hospital, trying to see the people who are ill for other reasons. And that always gets worse in winter. For reasons, in honesty, I've never quite understood. But we always see more chest infections, heart attacks and other problems. So we get those dual pressures, which is what we have at the moment.
And is it possible to battle this new surge at the same time as rapidly rolling out vaccines, which is the kind of juggling act going on in the NHS at the moment?
Yes, it is. The way that's going to be possible is entirely dependent on the public. And I don't want to victimise people who've caught COVID, because that's not fair. And there are people who are poor, who are crammed together in poor housing, who have extended families living with them, who have children who go to school, who bring that disease back, who are made to go to work in conditions where it's hard to avoid contracting the disease. That said, a lot of this disease is spread by people who are not behaving properly. 50% of people will have no symptoms or such mild symptoms they won't even know they've got the disease. And they can spread this disease rampantly, and particularly this new version that has a transmissibility that's at 56% higher than that was there before. And this was already a very contagious virus. So my plea is that we do know this has been an appalling year. And believe me, I'm every bit as fed up with it as anyone else watching this is. But we can't just throw the towel in and start partying, and particularly as we look at the new year. We're in real trouble now, and if people decide to have one last fling, it might be their last fling or that for someone else. Because when the disease is spread, we don't see people with acute COVID hitting hospitals, usually for around 7 to 10 days. And that's when they fall off their perch. So we're getting hit with the wave of stuff that was happening in the run-up to Christmas right now. If people behave badly tonight, we're going to get another layer of that hitting us sometime around January the 7th to the 10th. And we're already too stretched. So my plea is, I know it's been dreadful, but please, 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 please just keep your social distancing, alcohol gel, mask, and please don't have one last fling this evening with a party, because you don't know what you're doing if you spread that virus.
And when you're working flat out, nursing staff also absolutely stretched to the maximum, what goes through your mind when you see people out and about, gathering in crowds, gathering together without masks?
My rational brain understands. We've all had enough. We're all fed up. I also understand that unless you're medical, you perhaps don't understand that you can be completely asymptomatic and spreading it. That many people, especially when they're young, have never met someone with this disease. So my rational brain understands why people might behave like that. My emotional brain, I'm incandescent with rage now. I cannot bear it when I see people without masks. And, you know, we had a delivery driver delivering more critical supplies to intensive care yesterday who walked in without a mask on, any mask, and got very shirty when I asked him to put one on. It makes me so angry. I'm watching people die in this hospital, and me and my colleagues are seeing families affected here. Mother, father, children. It's not funny. It's really not funny. And I'm cross now. People understand the message. I know it's difficult, but we've just got to stick to the rules. It's hands, face, space.
You've been clear about the help you need from the public. What help do you need, for example, from the military and ICUs where, for example, the oxygen is running low? What help is needed there from the government, the military? What do you need?
Well, I think from the oxygen supplies, those are engineers dealing with that. There's plenty of oxygen in Britain. The issues are engineering ones related to supply pressures. And that's partly a success story. We've found ways of avoiding putting people on breathing machines with tubes down them, paralysing them, and using tight-fitting masks and what's known as high-flow nasal oxygen. But that takes a lot of oxygen. It's very, very oxygen-consuming. There are devices being invented now, which I'm hoping government would support to get rushed through, that would dramatically lower that oxygen requirement. So I'm hoping that those might appear soon. But in all honesty, I don't think, and this isn't a criticism of anybody, I just don't think there's a ready technical fix to this. The problem is that we've got both taps open in the bath and the plug hole's very small. And if we keep pouring patients in at the top, the bath will overflow. We've got to turn the taps off. We've got to get people to start behaving.
And you've talked about how stretched staff are. Is it a staffing issue to blame for the fact that the Nightingale hospitals are standing empty? A lot of people are baffled as to why that is when people seem to be so stretched in ordinary hospitals.
No, it's a very good comment. And again, the Nightingales, as originally conceived, weren't a mistake. They were conceived for a disease that we were guessing would come, which was probably a pandemic flu. It's just that COVID-19 isn't pandemic flu. It's a very different disease that affects the brain, the lungs, the heart, the kidneys, the liver, the muscle, the skin. It's a whole body disease. So the idea behind the Nightingale originally was a very good one, in that for simple ventilation, for simple lung problems, it would have worked fine. But this isn't that disease. So what's been done well, I think, is to try to expand the bed numbers inside hospitals with good ventilators and the sorts of support that can manage those critically ill patients in centres that can deal with multi-organ failure. The problem remains, though, it doesn't matter where the patients are, the problem remains that you just can't train up intensivists and nursing staff that quickly. That's the problem. You just can't train them up fast enough.
So as things stand, those Nightingale hospitals are next to useless?
Well, no, what's happened in London is that the Nightingale, which was at Excel, those beds have been expanded into hospitals. So there's been building work done in the summer months, for instance, to add floor space, as well as ventilators and equipment inside hospitals. So our capacity in London, for instance, and I can't speak for other regions, but our capacity in London now is very, very much larger for intensive care than it was in wave one. And we can sort of cope with that by doubling up nurses. It's dreadfully hard for them to manage more than one patient at once, sometimes two. I've got colleagues where nurses are back to managing 4 patients on intensive care for each nurse. It can be done. We've done it before. But what we can't do is allow that number to keep rising, because there is a limit. We talked about this limit to elasticity. There is a limit to how many people can be safely looked after. We'll keep adding them. We will keep looking after patients. But it gets increasingly difficult the more we add. We are moving people around London, and my hat's off to the absolutely fantastic transport team. Some of my intensive care colleagues are out in ambulances pretty much day and night now, moving patients from hospitals that are overstretched into something that has extra Nightingale capacity. But we're very, very rapidly running out of that capacity now.
And just finally, just give us a sense of the toll this is taking on staff, on you, on your colleagues, particularly when there's a lot of people who are speaking out about the problems are getting abused on social media.
Yeah, I've stopped looking at social media for that reason. It doesn't serve any purpose, really. It's very, very hard. As I say, many of us as consultants in intensive care, we chose this career, and I'm delighted to be allowed to do the job, and I'm privileged to be allowed to do the job. I find it tiring, but I don't find it emotionally stressful to be made to work hard. I find it emotionally distressing to see young people orphan their children. But I don't find it stressful to myself. For the nursing staff, it has been utterly awful. And I do think that this sort of second hit is going to be not too much. They will carry on. They're very resilient. But it was such a brutal and bruising experience first time around that I just don't want it to be done again. And it is within all our hands to stop that happening. It really is. It is within all our hands. We cannot rely on a government edict and then blame government when a tier X doesn't work. It's in all our hands, and it is difficult. I do get it. But we've all got to do our bit, please.
And what do you say to people who are spreading disinformation on social media about how stretched hospitals really are?
I find it hard to know what to say to them because I don't understand the motivation. If it's just malevolence, then I have no truck with it at all. I guess part of the problem is if people are poorly educated, don't understand how to weigh sources of evidence, and perhaps don't listen to the more credible media such as yourselves, who might report things sensibly, then maybe if your social media feed is designed by artificial intelligence to keep feeding you the same stuff, maybe that's the problem. Maybe people are buying into a narrative that's in some massive echo chamber. And I guess it is difficult because we can't show people what's happening in here for obvious reasons. Patient confidentiality, we can't go around filming people when they're poorly, and it's not safe to have people coming in. We're back to where we were before. We can't have relatives coming in, for instance. So it's hard for us to show, and I get it. If you're outside, you wouldn't know, would you? You walk through central London, you would never know what was going on inside these hospitals, let alone Birmingham or Portsmouth or anywhere else in the country. I guess you just have to believe us. I've got no vested interest here in lying.
Give us a sense then of the ward that you're going to go back to now. Paint us a picture of what's happening there right now, the kind of patients you're dealing with.
For us, I could really say is pretty much like everyone else. These are the same sorts of patients we had first time round. The sad thing is that when people are very elderly and debilitated and they get COVID, we often don't see them because they die at home or they die in a nursing home because the families or the patients themselves have decided that their life is nearing an end anyway. And actually, there's a limit to what medical practice can do to save a life like that. So the idea that hospitals are full of people in their 90s at the very end of their lives, seriously debilitated, isn't true. On the wards, it's generally people with one or two minor conditions or none at all, slightly raised blood pressure. When we hear this story about patients having other medical conditions, we're not talking about people who are moribund. We're talking about people with the sorts of things that all of your listeners might have: a bit of raised cholesterol, a bit of high blood pressure, whatever. And the ones who make it to intensive care have to be the ones where we think we might be able to save their lives. And that does require you to be reasonably well. Patients with very bad lungs to start with, or bad heart failure, for instance, or other conditions, often can't come to intensive care because it would be futile were we to try to save those lives. And that's really cruel. So the patients we're managing are my age. I'm 58. So most of our patients, as before, are my age, sort of middle-aged, maybe a few a little younger. We and other hospitals have been managing people in their early 30s, right the way up to people in their 70s. I guess the average around us is probably middle-aged. And we are shipping people out a lot. So we've used a lot of transport to move people from us to other major centres in London. Our concern now is we're into the stage, as many others are, with patients who become increasingly difficult to transfer. They get sicker rather than better on intensive care for a while, and it's hard to then start moving them. So you then start getting a system that's quite log-jammed and constipated with people that can't be moved. And if we reach that stage, then of course we start filling up further from there. And that's what I'd like to try to avoid.
Hugh Montgomery, thank you so much for joining us. I'll let you get back to your busy job there.
Thank you, Kathy. Thanks for having me.